Hello and welcome to the CAUTI prevention presentation for Nurse 456 Senior Practicum for ECPI University. My name is Taisha Watson and I am presenting this to Surgical Oncology at ECU Health. So catheter-associated urinary tract infections are the most common healthcare-associated infection and is the fourth leading cause of HAIs in the acute care setting. It leads to 13,000 deaths annually with a mortality rate of 10% and can lead to bacteremia and sepsis. The longer a catheter stays in, the greater risk for infection. So about 5 days, you're at a risk of 35%, and at 30 days, you're at a risk for 100%. It can cost the United States $340 billion a year, and it's not reimbursable. So Medicare does not pay for the extra days that cause the extra medication, the extra diagnostics. Medicare doesn't cover it. So when a catheter is inserted, it causes ischemic changes and erodes the bladder mucosa. Because the bladders are considered sterile, when a Foley is inserted, that introduces bacteria to the bladder. There usually is one type of bacteria from the perineum that's introduced to the bladder on catheter insertion, but it provides an ascending route for bacteria to travel from the perineum. Once the bacteria is inside the bladder, it forms a biofilm, which helps it proliferate. So then the bacteria begins to colonize the bladder, and it can grow from one type of bacteria to up to 5 different types of bacteria. Patients with different comorbidities like diabetes, which causes glucose to be in the urine, are at risk for CAUTI formation, along with women, the elderly, and immunocompromised. Once a CAUTI forms, it can extend the hospital stay from 2 to 5 days. So the ECU Health Urinary Management Policy, you can find that on the facility's intranet and then go into a polystat. It's reviewed and revised every year, and it's actually due to be reviewed and revised in July of 2023. So this year they will be reviewing that policy and revising it as needed. And our policy states that serious infections can lead to an increased stay or result in death, and we should avoid the use of catheters unless it is determined appropriate. So when the provider orders a catheter, they have to choose the criteria in their order. And the criteria also for inserting and removing the Foley and post removal is on the internet on polystat in this policy. And what they recommend is that repeat bladder scans with intermittent in and out catheterization for acute bladder retention is the best evidence-based practice. And that staff should be validated before inserting or giving Foley maintenance, and should be observed by a preceptor during orientation. There are modules on My Learning Center under your tasks that we get annually on prevention of CAUTIs, but you also can check MOBIES, which is on the intranet as well. And you can also find a link on polystat to refresh your Foley maintenance and Foley insertion knowledge. The policy also talks about perineal guidelines, which should be once daily after bathing and as needed after bowel movements. So the policy states that the tubus should be secure after Foley insertion, and that a closed system should be maintained. So there is a seal, usually it's a red seal, that's on the catheter connecting to the drainage bag, and it should not be undone, because once compromised, that means there's an increased risk for infection, because that means bacteria, the seal has been broken, so bacteria can also get in through that area, that connection between the bag and the catheter itself. The drainage bag should hang below the bladder, but not touch the floor, because that is also an infection issue. And tubing should not be kinked, so that there's not any stagnant urine in the tube, and so that you can have appropriate urine flow from the catheter to the bag. So a catheter may need to be changed due to obstruction or CAUTI, but you don't make any routine changes to the Foley. If it can be removed, then you just let it stay out, but you don't change it as you would like a dressing change or a change in the IV site. You can use STAR, which is stop, think, act, and review, prior to removing the Foley, where you would assess if the patient still needs the Foley or not, using your nursing judgment of whether you should remove it. You also can use alternative devices for incontinence, and we will be talking about those on the next slide. Assess for changes in voiding and intake and output. So if you have removed the Foley and the patient hasn't had any output in 4 hours or so, then you would do a bladder scan. And if it's greater than 300, or is it 350 mLs or greater, then you would do an in and out catheterization. And if it's less, then you would just continue to assess the patient and encourage the patient to use the bathroom. If you have to insert a Foley, you would use a Foley buddy to assist you with insertion, because sometimes it can be difficult to insert a Foley on different patients. But also, if there's any steps that you might forget, that Foley buddy can back you up and remind you of the steps that you need for a sterile technique with Foley insertion. And of course, early Foley removal is the best way to prevent CAUTI. So continue to assess your patient, and if it's not indicated for that patient to still have a Foley catheter, then remove it as early as possible. And to make sure to document all of these things, because if it wasn't documented, it wasn't done. So you want to make sure that you keep up on your documentation, because documentation also helps prevent CAUTI. So this is a removal and post-removal protocol that you can find on Polystat. It actually looks this blurred on Polystat itself, and I tried to download it and clear it up, but it's still a bit blurred. So ECU Health could definitely clear this up, so we're able to like print it out and have it with us, or you can always go on Polystat to review it again, to help you decide when you should remove a Foley. So it gives you some indication to determine whether or not to remove a Foley. First, like if the patient is recovering from surgery, bladder surgery, kidney surgery, if the catheter was placed by urology. Of course, we work surgical oncology, so we when we do get patients that have a Foley that's placed by urology, they would specify, they like, do not remove Foley until we order it, until we tell you to. If the patient has a lot of blood in their urine, if they have clots in their urine that's impeding urine flow, impeding their output, open perineal or sacral wounds that are unable to be kept dry, urinary retention, but they're not a candidate for in and out catheterization, or if they're an ICU patient. So first you would look at the indications when you're trying to decide whether or not to remove a Foley. And if the patient has any of these things going on, that means the answer is yes. So then you do not remove the Foley, and you would just continue to assess the patient daily and discuss with the provider on what the plans for the catheter is. But if the patient doesn't have any of these things going on, you would say no, and then you would remove the Foley catheter and discontinue the order. So after removal, you will monitor the patient for output. So it's been 4 hours or so, and the patient still hasn't gone to the bathroom on their own, and then you would bladder scan them. And if they have greater than 350 mLs, then you would do an in and out catheterization. But if it's less than 350, you maybe continue to monitor the patient, encourage them to use the bathroom. If they're able to ambulate, maybe get up and go to the bathroom, because some people can't lay down, use the bathroom. So you would try to do different things to get them to use the bathroom. So other things that are on Polystat is the CAUTI prevention bundle guidelines. So these are things that you just have to remember to do when you have a patient that has a Foley. You will review their health record and make sure that there's a order for the Foley with a clear indication on why the patient has to have the Foley. You could talk to your charge nurse if you are concerned about the patient having a Foley. You can go over the post-removal scanning orders, because usually when the Foley is ordered, it'll also have like bladder scan orders if there are orders to DC the Foley. And also make sure you know the Foley alternatives. And like, you just don't go and place a Foley on someone just because they're incontinent. You could look at other alternatives to use if the patients have difficulty voiding. So every day you should be assessing that Foley care has been documented. Of course, Foley care should be documented after every bowel movement. And you also should document if the patient refuses Foley care. The drainage bag should also always be hanging below the level of the bladder, secured and off the floor. And of course, we want to assess the tubing to make sure there's no significant dips or coiling or kink, so that no stagnant urine is in the tubing. And of course, document if you are inserting the Foley and making sure that you have placed the Foley itself on the LDA on the patient's EHR. Document who your Foley buddy was, and a reason if you didn't have a Foley buddy with you. So this information, this guideline, if you ever need a refresher on it, is also on Polystat. So these are the links that are that could get you to Polystat. You also could just go on the internet and search Polystat, and it will pop up. But this is the viewing urinary management policy. They also have on Elsevier the standard protocol on how to insert a IUC Mosby's. It's on Mosby's. And also the checklist, if you need to have something with you so you can remember all of the things you're supposed to do with inserting the Foley, you can print out the checklist. And then also if you need a refresher on the indwelling urinary catheter maintenance, that is also on Mosby. Now, these are some of the alternatives that we use on surgical oncology if we're trying to keep a patient dry, if they're having a problem with incontinence, and if we also need to monitor the urinary output, but they're incontinent. And so they can't use a urinal, they don't ambulate to the bathroom, so we can't use a hat in the bathroom with them. So the top one is a condom catheter, and the bottom is a PureWick. So if a patient has a penis, then you would use a condom catheter to keep them dry if they have a sacral wound or a wound that's in their perineum that is at risk for getting wet due to incontinence. You would use a condom catheter. And then the PureWick is if a patient has a vagina. This also, you can use this to help monitor their output and also to keep them dry if they're at risk for an ulcer forming due to moisture. If they also have a wound like a sacral wound or a wound on their bottom that we're trying to keep dry, we can use a PureWick. And with both of these things, you still have to document that the patient has a condom catheter or a PureWick, and you also should document and make sure you're doing peritoneal care and also assessing their skin every shift, because they still are at risk for skin breakdown using those items. So now some new interventions that different facilities use. Electronic prompts to let you know when a patient has a Foley, and to make sure that you are tracking how many days that a patient has a Foley with daily alerts. and it requires documentation every shift. Some facilities do weekly audits of their Foleys to make sure that they are, like, they do the audit, they make sure Foley care is being done, and make sure that it's pulled when appropriate, and make sure that if the Foley was removed, that's also documented. And then some facilities have CAUTI prevention teams that have weekly meetings, so they go around and check all the patients that have a Foley. They check their charts, make sure that everything's being documented, but also making sure that the staff is adequately trained on Foley management, on insertion and removal. And also a bedside checklist for Foley insertion and maintenance. One study that I researched while doing this project used a bedside checklist in the room. So this is a checklist. It was used in Auckland, New Zealand, that they had in every patient's room that had a Foley. And I thought it was interesting because on our EHR, it just has a short assessment of the Foley, and it just asks the question, Foley care done, yes or no? Now, presently on our unit since September, when I started, we have been doing an extra checklist where we document every time Foley care is done after a bowel movement, and we also put who we did the Foley care with. So we have been documenting the Foley care buddy, and that has been great. But on the EHR itself, it just says yes or no, and you either say yes or no if you've done Foley care, but it really doesn't go in depth on what has been done for the patient in regards to their catheter and preventing CAUTIs. So I thought this was interesting. This checklist has components of care to prevent catheter-associated urinary tract infection. And because we are a surgical unit, a lot of times if we receive a patient with a Foley, it got placed in pre-op, and if it wasn't removed in PACU, say because urology placed a Foley, then we'll get that patient with the Foley already placed. So we don't place a lot of Foleys on the unit, but we get patients with Foleys from surgery. So we might not always fill out insertion technique unless we've had to in and out catheter patient multiple times and they're still retaining, and then the doctor says, okay, we're gonna put a Foley in, then we would fill out this part. But the three main parts I thought was interesting that I thought could be added to the EHR, or maybe we would have this form or a form like this on the unit for us to fill out when we have a patient with Foleys, is the hand hygiene, the catheter maintenance, and catheter removal. So hand hygiene, of course, is very important. You want to make sure that you're doing hand hygiene, especially for us on the unit when we get the patient that already has a Foley, before catheter manipulation and after catheter manipulation. And of course, catheter maintenance is very important, but we don't know if everyone is doing this when they say they do Foley care. So it's just a yes or no question on our EHR. So collecting bag being below the bladder at all times, checking the tubing, urine collection bag off the floor. You know, sometimes you do come in the room and you do your first assessment at the beginning of the shift, and sometimes the bags are left on the floor, and so we have to make sure to put them in a designated spot on the end of the bed. So there's something, if we are making sure everybody checks this off, we will have less people, like it would be like a reminder that the bag should not be on the floor. Sometimes it's on the floor on a pad, sometimes it's just laying on the floor itself. So there's something that we need to be taking a look at, because that is an infection prevention issue. Making sure that the collected bag is emptied regularly, because sometimes the bags start to leak and look like they're about to bust, or about to burst, especially if the patient is having a lot of output. Like with CBIs, you have to assess with continued bladder irrigation, you have to assess the bags more frequently to make sure they're not overfilled, and also that it will back up and cause pain to the patient. So you want to make sure that you're emptying the bags regularly. Use a separate clean urine collecting jug for each patient. So make sure a patient always has a urinal in the room. And then contact of the spigot with the collection jug is avoided. So you don't want anything really touching that spigot when you're emptying the bag. You don't want it really touching any other surfaces, because that could also be introducing bacteria to that closed system. And of course, routine hygiene, doing your perineal care, daily bathing, after daily bathing or showering, and of course, after every bowel movement. And then, of course, catheter removal, it needs to be assessed daily. So are you looking at the chart? Are you assessing the patient? Do you feel like maybe they could start getting up and going to the bathroom on their own, or that they're alert and oriented enough to use a urinal or request a bedpan? If there's no issues with the patient being able to go to the bathroom on their own, then you would remove the Foley. And then, of course, you would put a date in your signature that you removed it. So I just felt like this, out of all the research I did for my project, that this was interesting, because it just has a few more steps to like jog your thinking, jog your mind on what you're supposed to be doing when you are assessing your patient with a Foley. Because sometimes they'll be like, oh, the patient hasn't had any output for a few hours, so I'll go in there and check the tubing, and there's urine in the tubing, but it's a kink. It's almost like a knot in the tubing. So I straighten it out. I make sure it empties in the bag. And it sometimes it's like 200 or 300. Like, oh, that's why it looks like the patient hasn't had a lot of output, but no one is assessing the tubing. So this just to remind you of the things you could do when you're maintaining Foley. So some things to remember is nurses have the most contact with patients. Proper documentation is key for improvement. So if it wasn't documented, it wasn't done. That's why I always try to ask, like with the care partners, because we're working as a team, like, has Foley care not been done? Or if I haven't seen it documented, I'll go ahead and do the Foley care. But I'll ask, like, have you did your Foley care? Make sure that you put it in the chart. Especially if I seen the aide do it, or I was with the aide, we were turning the patient, we cleaned the patient up, and I know that they did Foley care, but then I don't see it documented, because I want to make sure that everyone sees that my aide has done what they're supposed to do. So I remind them, you might seem like you're being a busybody, but it's like, hey, make sure you document your Foley care, because documentation also helps with CAUTI prevention. Avoid unnecessary catheterizations. So you wouldn't just place a catheter in someone just because they're incontinent. That's why we have those alternatives like the condom catheter, like the pure wig. Maybe you might need to assess them more often, like if they're Q2 turn. Also ask them if they need to use the urinal, if they need the bedpan. Just assess them more if you want to make sure you keep them dry, so they don't have any skin breakdown. But you don't just place a catheter because a patient is incontinent. So no unnecessary catheterization. There has to be a clear indication on why the patient is receiving a Foley catheter. Always use sterile technique when inserting. Of course, if you're not sure about sterile technique, you could always go on the internet to Polystat to refresh yourself with the sterile technique that we use when inserting Foley catheters. You could go on Mosby's. I know they have videos and checklists and everything like that for you to use if you just need a refresher course on Foley insertion. Assess the need for Foley each day, but also each shift. A person might be doing better in the evening than they were that morning, or they might be doing better in the morning from that last night that they needed the Foley, but this morning they're more alert and oriented. They want to get up out of bed, they're ambulatory. Then we could think about pulling the Foley. Clean technique for maintenance. Make sure hand hygiene is very important. It's universal standard precautions that you always make sure that you do your hand sanitizer or wash your hands before and after any test with the patient, but especially when we try to prevent hospital-acquired infections, especially with Foley's. And of course, use your autonomy, use your nursing judgment. If you feel that a patient doesn't need a Foley anymore, you can use your critical thinking, your nursing judgment on whether or not you should pull the Foley. And you have the protocol, the removal protocol on the intranet, on Polystat, if you need reminders, if you need assistance with making your decision. And of course, the provider is always there too for you to discuss whether or not the Foley should stay in place. Here are my references of some of the uh, articles that I use for this presentation. I thank you so much for being with me today, and I will see you on the unit.